prescribe these medication itself. So if your patient population is like in their 50s, then yes, or if you're anything, if you're more than 10 years postmenopausal, then these agents are not are contraindicated for older people. So what sort of agent do we use? So they are bisphosphonates. We have RANK ligand inhibitors such as denosumab, and also parathyroid hormone receptor agonists. So this table actually basically shows you the preparation that we have in Malaysia. You have alendronate, risendronate, ibandronate, zoledronate acid as well. And most of these agents actually works in reducing fracture risk. Only thing that has not determined effect is your ibandronate, just because that in the studies the patient population was not powered to show a reduction, to show evidence of reduction in hip or non-vertebral fracture itself. But the rest are fairly effective. So I just like to show you the site of action of these three different agents. So for example, your bisphosphonate, after you've taken it, it binds to your bone surfaces. So what happens is that your osteoclasts, when they attach to these bone surfaces, they get impregnated with this bisphosphonate bones, and that would actually causes apoptosis of this osteoclast, and they die off. So bisphosphonate is the only one that binds into the bone, and hence even when you have a drug holiday, your BMD does not drop so drastically because it's actually in your bones already. Whereas denosumab, how does it work? So your osteoclast cells actually have a receptor called the RANK receptor, and they will require the RANK ligand to bind to this RANK receptor to activate the osteoclast. So what denosumab does is that it binds and inhibits this RANK ligand and prevent the maturation of this osteoclast, and hence cause cell death in the osteoclast itself. Where parathyroid hormone is the only bone formation agent, it's an anabolic agent. It actually stimulates your osteoblasts to form bones. So it's the only bone building agent itself at the moment. Okay, so does bisphosphonate works? So yes, I mean it's one of the oldest agent that we have, and it is cost effective. So one of the papers, the initial papers, the FIT trial, shows that in patients with pre-existing fractures, that means we're talking about secondary prevention. So this group of patients already had a previous fracture, and if you put them on alendronate versus placebo, you will find that patients on treatment actually has increased BMD on all the sites measured, whether it's your femoral neck or total hip or your spine. And not only does it increase BMD, because we also want to see whether it actually reduces fracture risk, because there's no point having higher BMD but no reduction in fracture risk. So it shows that there is 50% reduction in vertebral and hip fracture in the FIT trial. So a sub-study from the FIT trial, when they look at what about patients for primary prevention, that means they do not have previous fracture, but they do have a low BMD score. So it's also known that the effect is better with the much lower BMD scores than the one with a BMD score between less than -1.6 to 2. So if your BMD score is less than 2.5, the effect is better. The increase in your BMD is higher in those patients. And it does actually also show a reduction in vertebral and hip fracture, especially in those with much lower T-scores. Okay, so I just want to also talk about zoledronate acid, the Horizon trial. So this is intravenous agent where you give it once a year, up to 3 years. So it is effective. It is one of the most potent bisphosphonate because it has highest affinity to the bone compared to the other bisphosphonates. And it can cause a reduction in your hip fracture by 40% and 50% in vertebral fracture. And it is the only agent at the moment that managed to show a reduction in mortality. This is when it was being administered in patients with hip fracture. So this may be a game changer, especially for hip fracture patients. And the side effects is that some patients may develop problems with fever, myalgia, and lymphopenia with the infusion. So infuse it in about 15 minutes. Normally, if you worry about this fever or myalgia, normally you can give paracetamol prior to the infusion. And the subsequent infusion, the risk of them developing this transient acute phase reaction is lower with subsequent infusion. It usually occurs mostly in the first infusion. So for patients who may have problems with GI side effect, then you could use alendronate acid. But all bisphosphonates are contraindicated in patients with renal impairment of eGFR less than 35 mils per minute. So what are the adverse events with bisphosphonates? You can cause esophagitis, esophageal ulceration, but if you get them to take it in the appropriate instruction, normally the risk of that occurring is lower. So there are some uncommon side effects, and everyone worry about osteonecrosis of the jaw, but it is really rather uncommon. And it's more, even when it occurs, it was usually seen in patients who actually have high doses of bisphosphonate, or if they have IV bisphosphonates for skeletal complications of malignancy. So it's a good practice, get your patients to see a dentist and get cleared for not requiring any dental work. Then only start them on bisphosphonates. So atypical fracture can also occur, but also rather rare. So if your patients who are on bisphosphonates come back and tell you they've got thigh pain, make sure you do an X-ray of both thighs, because the prodrome is usually thigh pain or groin pain, and these patients may need surgical intervention. So for drug holidays are only for bisphosphonate, not for any other agents. And if they've taken bisphosphonate for 5 years, you assess their risk. If they are at low or moderate risk, then you can consider stopping and monitor them every 2 to 4 yearly. 2 and 4 yearly actually. And if they are at high risk, you have an option, you can continue the bisphosphonates for up to 10 years. So they are the FIT extended trial that patients were on it for 10 years without any major complication noted. But obviously then the risk of atypical fractures or osteonecrosis of the jaw may be a bit higher, but still in general, the percentage is low. Okay, so I'm just going to tell you about denosumab. Denosumab came out in the FREEDOM trial. So this is giving subcutaneous injection every 6 monthly. So when you compare denosumab injection with placebo, you could actually see that denosumab can increase your bone mineral density in all sites as well, and it has actually good fracture reduction risk in your vertebral fracture, hip fracture, and also non-vertebral fracture itself. So this agent is the only anti-resorptive agent that you could still use in reduced renal function. But then again, I have to say it's up to your eGFR of 15. Anything less than 15 mils per minute, we don't have any major data about it. But I know that there are some trials we look at patients with end-stage renal failure. You just have to be cautious in those patients. You need to make sure that the calcium level doesn't go drastically low following that. The risk of hypocalcemia will be higher in these patients. So when the sub-study look at denosumab and patients with reduced renal function, they find that the BMD still increase and a fracture reduction risk is also there. So it still can be used for patients with lower renal function. Okay, so what about after 3 years? The FREEDOM trial is up to 3 years. So they look at patients after 3 years. So this is an extension. So if you look at the FREEDOM initial study, that placebo and denosumab. So now in the subsequent study, the patients who were on placebo were swapped to denosumab then, and they continue it all up to 7 years. So it's 10 years in total of taking denosumab. So let's see what it does. So it shows that your BMD continues to rise, up to 10 years, and it doesn't plateau to a stage. So even the subsequent years, there will still be a BMD rise in most of the regions like your lumbar spine, femoral neck, and even in your whole body BMD percentage change. Yeah, and what about fracture risk? So because in this trial, when they extended the trial, all these patients were already on denosumab, so you can't actually compare it with placebo. So, but they noted that the fracture risk remains to be low in terms of your new vertebral fracture or hip fracture up to 10 years. So there is safety data up to 10 years of treatment, and the common side effects were possible infection, especially cellulitis, not exactly at the site where you inject the denosumab really, so some people may complain of cellulitis here and there. The other thing is that it can still possibly cause osteonecrosis of the jaw or atypical femoral fracture, but the risk is very low. Sorry, I'm running out of time. Yeah, okay. So just to let you know that when you start denosumab, what happens if you stop it? So in the Freedom trial, there are patients who were supposed to be on it for 10 years, but they were patients who actually stopped by year 8. So you could see that your BMD continues to rise, but after when you stop it, there is a reduction in your BMD scores. The same like in another trial when they look at what if the patient miss 2 doses of denosumab. So that means they may be off denosumab for a year. There is a drop in your BMD. And then when you restart it again, the BMD does rise, but it takes that time. So the worry is what happens during that drop when they look at, does it relate to increased fracture risk? Well, basically, it doesn't say that the risk is higher than patients who were not on who are on placebo. So the risk is just the same as if you're not on any drug. So it's not much higher than the usual. Okay. So the suggestion is if you were to stop denosumab in less than 10 years for whatever reason, or if the patient cannot tolerate, then you would consider changing them to another drug to maintain the BMD. Okay. So what I would say is that, I mean, for myself, I would consider denosumab to be the first-line treatment in certain patients. So, for example, patients who have polymass pharmacy already on 20 medication, then you would maybe want to consider denosumab injection. Patients who have shown to have poor compliance to oral drug, then denosumab would be useful. Patients who may have contraindication to oral bisphosphonate, for example, poor renal function, then you would consider using denosumab. Or patients who were on bisphosphonate but continue to show no rise in their BMD or a reduction in their BMD, then I would suggest you change it to a different agent. Okay, so now goes to your anabolic agent, teriparatide. It is the only bone-building agent for high-risk patients, especially. It works very well for vertebral fractures itself. You could take it up to 2 years, and the effect usually is best in 1.5 years itself. So the same, it actually shows increment in your BMD and reduction in your fracture risk. So this is to compare teriparatide and risendonate. It shows that teriparatide actually has a higher risk reduction compared to risendonate, and also reduction in your clinical fracture risk. So the adverse effects of teriparatide, this is a daily subcutaneous injection. Mostly it's nausea. Some people may get a bit of dizziness. Teriparatide is contraindication in patients who have hypercalcemia or if they have a history of skeletal or bone malignancy, then it's contraindicated. Okay, compliance with treatment is very important. So despite whatever agent that you have chose with the patient, it's no good if you're actually not taking it. So I just want to take just a couple of minutes before I end to introduce to you what the fracture liaison service is. It's actually mostly a hospital-based service, coordinated service to enhance secondary prevention. So that means you identify the fracture in the hospital, you assess their bone health and falls risk, you follow them up, you initiate the treatment, you investigate, and later on you also ensure that they adhere to the treatment. So that is actually noted to be an established treatment that improves outcome in patients for secondary prevention. So this is just how the algorithm looks like. Okay, so in summary, I just want to highlight that falls and fragility fracture should be addressed in unison. They should not be addressed separately. There is already sufficient evidence for the effectiveness of anti-osteoporosis medication. So whichever you pick, just make sure that it's tailored to the needs of the older person, taking into account their cognitive function, the mobility, the social support, and whether they are having polypharmacy or not. And just to let you know that fracture liaison service is something that is now being started in many different hospitals to help with secondary fracture prevention. So lastly, I just like to give you a present. So this is the second edition of the Auto-Geriatric book written by a group of Fragility Fracture Network experts. It's free to download. It's a good read, so you can download it